to have Dr. Mustafa Rawji with us. This presentation will cover changes in our vision as we age and the treatment options. Most in our audience are seniors, so the presentation will focus on issues of concern to the aged. Dr. Mustafa Rawji, an experienced optometrist, is a graduate of the University of Bradford in England. He completed his master's in vision science at the University of Waterloo. He has undertaken research work at the Toronto Western Hospital before setting up his optometry practice in Toronto. Amongst his volunteer services are his trips to developing countries with Global Kindness Foundation, where he conducts eye exams for children and adults alike. And he's been doing this for many years and has been to many, many countries. Dr. Rawji, the floor is yours. I've said enough. Over to you.
Thank you very much, Nazmunakal. Assalamu alaikum, everybody. It's an honor to come here and do a presentation for our community. So as Nazmunakal mentioned, the topic for today is going to be eye care for aging eyes. And specifically, we're going to be covering some of the common changes that occur as we get older. And these are presbyopia and floaters that many people complain of. And then we're going to cover some of the eye conditions that affect us as we get older: cataracts, diabetic retinopathy, glaucoma, and macular degeneration. Before we start talking about some of these diseases and the changes, let's just briefly go over the anatomy of the eye. Now, in order for you to better understand the anatomy of the eye, I'm going to use an analogy. Let's compare the eye to the camera. Now, if we want to take a picture, the way the camera works, we look to the viewfinder, we have a lens in front of the eye, in front of the camera, and we use that lens to focus the image. And once the image is in focus, then we press on the shutter release button, the shutter of the camera opens, and the image is captured into the film at the back of the camera. So the eye is very similar. In fact, I think the camera was designed based on the principle of the eye works, but here we'll compare the eye to the camera. So what we have, if you can see my pointer, we have in front of the eye, we have a lens, okay? And on the lens, on the top and bottom of the lens, you'll see those muscles. Those are orange. In orange are the ciliary muscles, and these muscles do the focusing for the eye. And in front of the eye, instead of a shutter for the camera, we have the iris and the pupil. Okay, and what the iris and the pupil are basically, it's a muscle structure. And what it allows us to do is to not focus the eye, not focus the image, but it controls the amount of light that's coming in. So you can imagine at night when it's very dim, we need more light coming into the eye to look at pictures and to make out images. So what the pupil does, or the iris does, the pupil dilates at night, but during the day when it's very bright or sunny, we don't need to have the pupil open as wide. So the pupil would constrict during the day, and this will regulate the amount of light coming in. So that's the function of pupil here and the iris. And then once the light comes through the pupil, it goes straight back into the eye, into the retina. And the retina is the posterior part of the eye. And the retina is made up of two important structures: the macula, and this is where the image focuses into. And from the macula, once the image is focused there, the impulses are sent back to the brain through the optic nerve. Okay, and these are important because when we talk about diabetes and glaucoma and macular degeneration, these are the structures that are affected by those diseases. That's why I'm pointing out to you. And so the retina basically serves as the film in the camera. And in the middle part of the eye, there's a gel-like substance known as the vitreous humor, okay? And that gel-like substance, the vitreous, it provides support to the eye. So you can imagine that these are very important structures that we have in the eye. And you can imagine as kids, when we're growing, we're playing outside, we're jumping up and down, or when we're playing sports, for example, we're moving at a very high rate. While all these important structures in the eye have to be cushioned. And the vitreous or the gel in the middle part of the eye serves that purpose. Now, what are some of the changes that occur naturally as we age? So many times when people come into my office, when they're at age of 40 or 45, one of the first things that they mention to me, or the reason they come to me, is they're saying that they have problem reading, doing close work, and that their arms aren't long enough. Okay, and this is known as presbyopia. I'm going to talk about that in a minute. And the other thing that sometimes happens as we get older is that we lose the sensitivity to light. So you can imagine if you're driving at night, sometimes we need more time to react to certain impulses than we would as when we're younger. And this is normal for the aging eye. So the first thing I'm going to discuss is presbyopia. So presbyopia is a natural age-related condition, and it is caused by the lens losing the ability to change focus as we get older. So remember I mentioned to you, if you look at the lens here, there's muscles attached at the top and bottom and all around the lens, the ciliary muscles. They focus the eye as we get older. They focus the eye when we want to look at an image or form an image in the eye. Now, as we get older, the lens loses the elasticity, so it cannot focus, contract, and expand as it normally would when we were young. So this is what happens after 40. So after 40, the plasticity or the elasticity of the lens is reduced. So we cannot, when you're looking at an image close up, we need to be able to accommodate, and we lose that ability of accommodating after 40 or 45. So in the 40s, it becomes harder for us to see things close up, but we can still see things far away. Now, how do we treat that? So basically, the first thing that we do is there are different options available for treating presbyopia, and the most common one is getting a pair of reading glasses. So when you come for your examination, based on your age and your distance prescription, we write our prescription, and you can get a pair of reading glasses that you can use for reading a book or a magazine. Okay, but the problem with just reading glasses is that you're going to have, most people end up with having a pair for distance and then a pair for reading, and it's very hard sometimes to switch back and forth. So then the most common option, or the next best thing, is to have a pair of bifocals. Now bifocals work in a way that the distance portion of the lens, the top part of the lens is for distance, and the bottom part of the lens is for reading. And the reading power is obviously a little bit stronger because we need that power to look up close. So then it's moved at the bottom. Okay, and the only disadvantage with the bifocal is that you have a line. So as you can see in the picture at the bottom here, there's a line that demarcates the distance portion and the reading portion. Now, there are other options available too. Now, if you use the bifocals, basically it's good for distance and it's good for reading. But sometimes when we're driving, for example, we can see far away, and we can see up close. But when you're driving, you want to be able to see the dashboard. Okay, but the dashboard is not at your normal reading distance. The dashboard is a little bit farther away. So then they came out with a trifocal. A trifocal basically incorporates the distance at the top, the intermediate in the middle, and the near ad or the reading portion at the bottom. So again, with the trifocal, so we have all three components, the distance, intermediate, and reading, but all of these are divided by a line. And for many people, they don't like to have a line showing through their glasses. So then many years ago, maybe 20 or 30 years ago, the next thing came out, and these were progressive lenses. So progressive lenses are basically like trifocals, which has the distance, intermediate, and reading, as shown in the bottom here, distance, intermediate, and reading, but there's no line. And that is advantageous because a lot of people don't want to wear glasses and to show and have the line showing. So you can get a pair of progressive lenses, and they will just look like your regular lenses, but you will have the intermediate and the reading power at the same time as well. But in doing so, the design of the lens is such that you end up with a little bit of blurriness on the side. So it's shown on the bottom picture here. It's a little bit of blurriness on the edges of the lens, okay? But that's very easy to get used to. So after 2-3 weeks, most people adapt to that. And the most common thing when people first wear progressives is that when they're looking sideways, they're looking through that blurry zone, and that blurry, it causes a little bit of distortion. So my advice to them is, if you want to look sideways, don't turn your eyes, but turn your head. So turn your head, and then when you're turning your head, then your focus is in the middle part of the lens, okay, not on the side. So if you're looking through, if you turn your head, then your focus will be to the distance or the intermediate, depending on where you're looking at, and you'll be able to see clearly without having the distortion on the side. So that's with progressive lenses. The next thing a lot of people complain or come to see us about are spots and floaters in the eye. So remember I mentioned to you, I talked to you about the vitreous gel, which is in the middle part of the eye. So those spots and floaters are harmless protein materials floating in the vitreous or the gel in the middle part of the eye. So by itself, they're not very serious, but if they appear larger or if they're associated with flashes, they may signify the presence of a serious problem as retinal detachment. And I'm going to explain that to you. So here is a sketch of the eye again. And as we can see, in the middle part of the eye is the vitreous gel, which is right here. Okay, so this is the lens, and behind the lens and in front of the retina is a vitreous gel. And so basically, as we get older, it loses its gel-like consistency and it becomes more liquidy. And then when it becomes more liquidy, then you start seeing these floaters in the middle part of the gel. And these floaters, because they're moving around in the eye, they cast a shadow onto the retina. And this is what most people describe as floaters. It's a shadow by these protein-like materials in the gel. And these shadows are most noticeable if you go outside on a bright day. For example, if you go to a park and if you're lying on the grass and if you're looking up, you're going to notice these floaters much more commonly, but they can be seen anytime, okay? Now, what are some of the other age-related conditions that we come across? And some of these pertain to diseases of our body, which then affect the eye as well. So the first thing I'm going to cover is cataracts. Now, again, so if you look at the picture on the right here on the top right, so we can see there's a lens in the middle part, in the front of the eye. So this lens, when we're young, is very clear. But as we get older, because it's a part of the body, just like the rest of the body, there's changes occur in the lens. So this lens starts becoming cloudy. So when it starts becoming cloudy, it's going to affect our vision. So it's going to, on the bottom left, you can see that this is the lens, a cross section of the lens, and you can see in the middle part that it's starting to becoming cloudy. And when we do the examination, this is how we see the appearance of the lens, okay? So it's becoming cloudy, and that's known as a cataract. Now it grows very slowly or gradually over time. So it might start at the age of 60 or 65. And then most people, they don't need to have the surgery done until in the 70s, maybe 75 or so, or after that. But normally we don't want it to get too dense, so it becomes a mature cataract, shown in the right. Then at that point, the vision is going to be very affected, and it definitely needs to be removed. Now, how do we deal with cataracts? So when you come in for a checkup, and if you start seeing that you are developing cataract, we can adjust the prescription in your glasses for the distance, and that prescription will improve your vision, okay, temporarily, until the cataract is ready for surgery to be done. And once the cataract is ready or mature, then surgery is required to remove the clouded lens, and it's replaced with an artificial lens. I'm going to show you that in a minute as well. And for most people, for those living in Canada, or maybe in the UK, in Canada, in Ontario, we have the OHIP insurance plan. This will cover the cost of the surgery for basic lenses, and will also cover your follow-up care after the surgery as well. Now, how is the surgery done? So again, here's a diagram of the eye. So remember, I showed you a picture before where the lens was sitting here, and it was getting cloudy over time. So the way the surgery is done, the ophthalmologist or the eye ophthalmologist will do an incision in front of the eye on the cornea. He will go and remove the cloudy lens, which is here. And through the same incision, he's going to insert a new intraocular lens. And this is what an intraocular lens looks like. It's a clear lens. It's an artificial lens as opposed to our normal, our natural lens that we have in the eye. And because it's artificial, it's clear, and it's not going to grow, it's not going to get cloudy over time. So once you have the surgery, this is a permanent solution, correction to your eyes. And this is how cataract surgery restores the vision in the eye. Next, I'm going to cover some of the diseases of the body which affect the eye. And the first thing is diabetic retinopathy. So diabetes is a condition which obviously affects the whole body, but in the eye, it acts by weakening and causing changes in the small vessels in the back of the eye, which are known as capillaries, that nourish the retina. Now, so because those capillaries are weakened, so what happens is that fluid or blood flowing through those capillaries start leaking, swelling, or you start developing new blood vessels in the eye, and those new blood vessels can cause bleeding inside the eye as well. Again, I'm going to cover that in a minute. So here I'm going to show you some of the changes that we see related to diabetes. So the most common changes that we see, and normally this occurs after 10 or 15 years of diabetes, is that we start seeing hemorrhage, shown on the left here, and those are bleeding. So again, those capillaries, the small blood vessels, because they are weakened, they start bleeding. It starts bleeding, and the bleeding appears in the retina, okay, in the back of the eye. And those, you can see that the various on the top here, there's a bleeding spot. There's bleeding all over the middle part of the eye here. And so that's one sign. And the other thing that can happen, you can get swelling or fluid leaking out from those vessels. And those fluid, when it leaks out, it causes these exudates or these yellow spots shown on the right, okay? And those swelling or exudates are seen here on the picture of the retina as yellow spot in the back of the eye. So this refers to swelling occurring in the eye. And as you can see, there's also a little bit of bleeding as well. So sometimes these go hand in hand. Now, these are early stages of diabetic retinopathy. At this stage, sometimes there's no treatment available or done for that. And the best thing that the diabetic person can do is to control their sugar, because once they control the sugar, some of the swelling and the bleeding is going to recede over time. Okay, but not completely, but most likely it's going to recede over time. And that's why when you see any of these changes, either the swelling or the bleeding, we normally see patients back every 6 months. We want to make sure that the bleeding is not getting worse or the swelling is not getting worse and it's not affecting their vision. So in the early stages, the diabetic retinopathy, or the changes in the back of the eye, may cause a little bit of blurry vision, or it may not produce any visual symptoms at all. So again, if the bleeding or the swelling is in the periphery, not in the middle part of the eye, it won't affect your vision. Okay, so on the right here, you can see the swelling is in the periphery, and it spared the middle part of the eye here a little bit. So it's not going to cause any change in your vision, but it's important for you to come for a checkup, because we can look at the eye and we can see the swelling and we can advise you on what to do, or if need be, we can refer you to have some treatment done. But as the disease progresses, the symptoms may also increase, and then patients may start experiencing cloudiness of the vision, blind spots, floaters, or other vision disturbances. So these changes that I mentioned are mentioned on this slide are the non-proliferative diabetic retinopathy, the early changes related to diabetes. Now, as the diabetes progresses and as the retina becomes more damaged, so one of the things that happens as with diabetes is that it causes hypoxia in the retina. So the retina is not getting enough oxygen over time. And when this happens, so the thing that we normally the next stage it progresses to is known as proliferative diabetic retinopathy. And this is a condition shown in this slide here, where you get abnormal blood vessels growing into the eye. So you can see here that all these vessels that on the left here are abnormal vessels. They're not part of the normal eye. And this is caused by the hypoxia or the lack of oxygen in the eye that's causing these blood vessels to start growing and to provide oxygen to the retina. Now, how do we treat that? Now, the treatment for these, there's two types of treatment. One is the pan-retinal photocoagulation. This is laser burns applied into the peripheral retina, shown on the right. And these laser burns, what they do is they reduce the oxygen demand of the retina. So it kills off the cells in the periphery. And by doing so, it reduces the oxygen demand of the retina, so that there's less stimulus for these blood vessels to grow. Okay, but normally this type of treatment is done when at the early stages of the diabetic or early stage of the new vessel. So sometimes when people come in for a checkup, when we start seeing tiny amount of small vessels growing in, this is when the laser treatment is done. When you have a big collection of blood vessels growing in, by that time it's a little bit too late, and it requires other forms of treatment. And the next treatment that's available is injection into the vitreous, or intravitreal injection, by a compound known as anti-VEGF. So these are vascular growth factor produced by the capillaries, which allows these blood vessels to grow. So these injections, once this type of changes are seen, are given every month, and it reduces the hypoxic demand of the eye, and reduces the small vessels from growing in. Now, diabetic retinopathy, if it's left untreated, it can cause blindness, and the most common cause of the blindness is the bleeding that occurs from these vessels that grow into the eye. And once damage has occurred, the effects are usually permanent. You cannot reverse it. Now, for people with diabetes, the retinopathy is controllable by taking the prescribed medication as instructed, sticking to a diet, exercising regularly, reducing the high blood pressure, and avoiding smoking. So these are all preventative steps that you can take if you're diabetic to prevent from the diabetic retinopathy from occurring or proliferating into the eye. The next condition that I want to talk about is glaucoma. Now, glaucoma refers to a damage in the nerve at the back of the eye, which causes a progressive loss of vision caused by the increased pressure in the eye. The fluid pressure in the eye increases or does not drain properly, resulting in damage to the optic nerve and nerve fibers. And I'm going to show that to you in a minute. So the most common thing that we see, the first sign that we see of this damage occurring in the eye is that the peripheral vision will start going in the eye, and then the central vision if it's left untreated. And it can go undetected for many years, and there are no early warning signs. So glaucoma is a very silent condition, okay? It's not going to affect your central vision, so you may not realize that this is going on in the eye. And there's nothing else to indicate that, there's no other symptoms that will indicate that this is occurring until you come for a checkup. And when you come for a checkup, what we're looking for is, first, let's talk about the picture on the left. So that this is the optic nerve, which is the nerve at the back of the eye. So normally it has a very pinkish appearance, but in glaucoma, when the pressure goes up, it causes damage to the nerve, and then you start losing the pink color, and then you start getting this cupping. The cupping is the increase in the white area that is shown on the picture on the left here. So that cupping is a sign that there's something is going on. There's damage going on in the back of the eye, and then treatment has to be initiated. And then now cupping by itself does not always indicate that there's glaucoma going on. Some people are born with the nerve, the cupping being large in the eye. So what we do, we do a visual field test, and it's shown on the right here. And on the visual field test, so somebody who has glaucoma, so this is what we normally tend to see in people who have glaucoma. So the central vision is intact, so they can see everything straight ahead. But in the periphery, they're going to have a loss of vision in the periphery in one eye or both eyes. And sometimes the changes, the peripheral loss in the vision is subtle. It's not as drastic as what I've shown here. And when we start seeing those changes, then we normally refer you to have treatment, in most cases, eye drops to control the pressure and to prevent more damage occurring in your peripheral, in your field of vision. And if the vision loss increases, then basically it's going to affect the whole of the eye, and then you'll be left with a very small central vision, tunnel vision, and where the central vision is spared, but the whole of the peripheral vision is lost. And this is the point this is the stage we want to avoid. So we want to avoid having for any patients to have that, and this is why we'd like to start the treatment at an earlier stage. So blindness can occur if it's left untreated, and because it causes no symptoms or signs, many people sometimes think everything is fine, but if it's left untreated for many years, blindness will occur. And once the vision loss occurs in glaucoma, it cannot be restored. The next thing I want to talk about is macular degeneration. Now, macular degeneration is a leading cause of blindness in US and Canada, and also obviously in Europe and other parts of the world too. It affects the macula, which is the central part of the eye where the image is focused in the retina. And the macula is the area of the eye responsible for clear, sharp vision, and it's located at the back of the eye. Symptoms include a gradual loss of ability to see objects clearly, and a distortion in the vision, and a gradual loss of color vision. So here are two examples of the type of changes that occur in macular degeneration. The early changes that we see are known as dry macular degeneration. And in dry macular degeneration, what we tend to see when people come in are these drusens, or these yellow spots in the back of the eye. And these yellow spots by themselves don't cause too many changes in the vision, but we want to monitor that. The reason we want to monitor it because we don't want this dry form of macular degeneration to become the wet form shown on the right. And the wet form is when this bleeding occurs at the back of the eye. And because it's affecting the macula, the bleeding will occur in the macula, in the middle part of the eye. And because it's affecting the macula, well, most people will not be able to see in the middle. So glaucoma affected your peripheral vision, but macular degeneration is going to affect your central vision. So most people complain when they come in is that they can't recognize people, okay, they cannot recognize faces. And then when they're reading, they have problem reading because they cannot focus the central vision into the letters or the pictures that they want to look at. And so this is what we want to avoid. Now, the treatment for the dry macular degeneration is there are vitamins that we can prescribe or that you can take that will prevent from this dry macular degeneration from getting worse or from getting into the wet form. But once the wet form of macular degeneration occurs, once you get bleeding at the back of the eye, the only treatment that's available is our injections. And again, injections have to be done by your ophthalmologist. And at that point, we refer you to the ophthalmologist. And these injections are given every month. And they can go on for up to a year or maybe 2 years because the bleeding causes a lot of damage in the macula. And so the treatment has to be given on a regular basis to prevent the bleeding from getting the vision from getting any worse. So many times people come in with a wet macular degeneration or bleeding in the eye. The vision is 2400, and then as soon as we refer them, they get injections every month. And sometimes, in some cases, I've seen people come back in 6 months, and the vision goes from 2400 to 2060 or 2040, which is a big improvement. And this is the advantage of picking up this condition early and having treatment done on a regular basis. So as I mentioned, there's no cure for the macular degeneration. Vitamins can help. And when it gets to the point where it starts affecting your central vision, you can have low vision aids or magnifiers prescribed to make the most of the remaining vision. And this is what macular degeneration looks like. So on the left here, when we're looking through into a field, our central vision, we can see the dogs in the middle, so we can see them clearly. But somebody who has macular degeneration, okay, the central vision is damaged and shown on the right here, so they will not be able to see the dogs or the faces of people, or when they're reading, they will not be able to see the text. And this is what causes the loss of the vision in macular degeneration. So finally, we're getting to the end of our talk now. I just wanted to, for those living in Ontario, I just want to go over the OHIP program, which is known as the Ontario Health Insurance Program. What does it cover? So basically, OHIP covers the basic eye examination for seniors after the age of 65 and kids under the age of 20 on an annual basis. It includes the follow-up visits, including visual field testing. So remember when I mentioned that in glaucoma, we have to do visual field testing. So if you're over the age of 65, the visual field testing is covered by OHIP. But there are other tests or procedures that we do in the office which are not covered by OHIP. So the most common one is the OCT or the retinal imaging. So when I talked about macular degeneration and diabetes, I showed you those pictures of the back of the eye that we take. Those are retinal images of the back. Okay, so this is the retina. So we're taking a picture of the back of the eye, and this is where we see the changes that are occurring, either occurring in the macula, the nerve, or in the blood vessels. Now, so that's the fundus picture that I shown you earlier. Okay, now the OCT is a more advanced camera, and it's like a CT scan of the eye. So what it does, it allows us to look at the layers of the retina, and it's shown at the bottom here. So here's the retina, and this is the macula which we're looking at right now. So you can see that the macula has a normal dip, and this is normal. But in somebody who has macular degeneration, the white spots that I showed you in dry macular degeneration, on the OCT, we can pick that up very easily. You can see that those show up as bumps on the OCT. So this is useful for somebody who has macular degeneration, also somebody who has diabetes, because in diabetes, when you get swelling, we can it's going to make the retina swell here, and we can see the swelling very easily, and we can pick it up. Sometimes it's very hard to see that with the naked eye, but with an OCT image, we can pick that up very easily. There are other pictures that we take of the eye as well. So one is it's an anterior segment imaging. This is not looking at the back of the eye, but it's looking at the front of the eye. So in the front of the eye, behind the cornea and between the cornea and the lens, there's a fluid through which we measure the pressure. And the fluid is circulated in this area and is drained from the channels in the front of the eye. Now, sometimes the channel that drain the fluid become very narrow and it gets blocked. And when it's blocked, the fluid cannot drain. So when the fluid cannot drain, the pressure is going to build up in the eye, and it's going to cause damage into the nerve. And when the pressure builds up to a very large extent, it causes pain also in the eye too. So many times people come in for a regular checkup. If we can detect these narrow angles at an early stage, there's treatment that can be given to create a channel for the fluid to drain besides the blockage. So that's an anterior segment image of the eye. Another picture that we can take in some cases are corneal topography. A corneal topography is a picture of a scan of the cornea, which is in the front of the eye. So the cornea is the front surface of the eye. And there's conditions known, the most common one is keratoconus, where the curvature of the cornea is increased. And then that affects your prescription in your glasses. And then when we do the corneal topography, we can pick that up right away. We can see the distortion or the curvature or the distortion that is present in the cornea. And this treatment that can be given to reduce that distortion or the curvature of the cornea, and thereby reducing the prescription in your eyes and in your glasses. Another type of imaging that we do often is for dry eyes. So many people sometimes when they come in for a regular checkup, there's a basic test that we can do to detect whether the eye is dry or not. And we can do that in the office very readily. And then most of the time we prescribe eye drops for them, but sometimes the eye drops don't work. So when the eye drops don't work, then we have to look at more, to get a more detailed picture of the eye. And this picture is known as meibography. And the meibography is looking at the glands on the eyelids, underneath the eyelids, and those glands produce the oily film of oil part of the tear. And when those glands become deficient or damaged, then it causes very dry eyes. And that dryness cannot be just controlled by taking eye drops. So if we take a picture, we can look at the glands, and if we see that those glands are atrophied, then there's a treatment available that can be given to rejuvenate those glands and have them produce the normal oil for the tear film. And the final thing that final procedure that or test that not covered by OHIP is contact lens fitting. So normally we see that in young kids when people come, so somebody coming in under 20, we do the eye examination and they say, okay, I don't want to wear glasses, I want to wear contacts. So what we do, so if they want to wear contacts, we have to teach them how to put the contacts in, how to take them out. And then we give them a pair of contacts to take home. They try that for a week. And if they're okay, then they can order contacts after that. So that's known as a contact lens fitting. That's a separate from the eye examination, and it's not covered by OHIP. So what's the benefit of doing a regular eye exam? So eye problems or even early stages of many systemic diseases can be detected during a comprehensive eye examination. And early detection is the key to preventing irreversible vision loss. So as I mentioned, I just shown you the example in diabetes, if we can pick up those early changes in macular degeneration, then we can prevent loss of vision, and also in glaucoma as well. So it's very important that you visit your optometrist, and I would like to suggest that you start visiting your optometrist at the age of 60 on an annual basis for a comprehensive eye examination, because we can pick up those early changes in glaucoma, macular degeneration, and we can try to control it at an early age before the vision becomes more damaged. And basically, that's the end of my presentation.
That's excellent. That's amazing. You covered a lot of ground. So, Dr. Rawji, we have a few questions coming through.
Sure.
Let me start right at the top. Somebody wears progressive lenses, but for the last 6 months, if he reads a book or if he looks at anything after a few minutes, he sees double. Or writing for a few seconds, yeah, he sees double, or writing even double. So what causes this, and what is the solution?
Okay, so progressive lenses by themselves don't cause the double vision. Okay, so if somebody's experiencing double vision wearing progressive lenses, it's most likely due to the muscles in the eye. So as we get older, the muscles get weaker. So sometimes the alignment of the two eyes is off a little bit. And when the alignment is off, then it's translated as double vision. So I think I would recommend that person to maybe go back to their optometrist and have a check to make sure that they're not having any problems with the muscles of the eye. Most commonly, when someone's wearing progressive for the first time, they will complain of the most common complaint that we hear is distortion, and the distortion is caused by the design of the lenses in the periphery. So double vision is not a very common problem, but again, it may also depend on the lenses that they have. Some lenses, if I can go back, let me see if I can find the. So here, the progressive lens that are shown at the bottom here. Some lenses have the distortion on the side have narrow corridor in the middle, and because that corridor is narrow, the distortion on the side is increased. So they may be experiencing. They may have just a regular type of progressive lenses, which with distortion, increased distortion on the side, which may cause double vision. But that's not a very common complaint. So first, I would maybe go back and have those progressive lenses checked again to make sure that they're done properly. If they're done properly, then I would recommend getting their eyes checked again to make sure there's no problem with the muscles of the eye.
Excellent. Excellent. Corrective lenses may cost a fraction of the amount online compared to the ones obtained as an optometrist. Are the online lenses inferior? And then secondary question is, what are SHAW lenses? SHAW, SHAW lenses.
Okay, Shaw lenses, I think Shaw is just maybe a brand name of a lens. It might be a progressive lens, or it might be a single vision lens, which has maybe a blue light coating or something else. So that I'm not sure exactly what the Shaw lens is per se. Now, with regards to the first part, when buying glasses or ordering lenses online, you have to be very careful, because when you come to an optometrist office, or you go to an optical store to buy your glasses, the optician or the optometrist will do a measurement, will take a measurement of the eye, the pupil of the eye. And that pupil, the centration of the pupil is very critical. So if somebody has a very high prescription, and if they order glasses online, and if those measurements of the pupillary distance is not very accurate, so a slight displacement of the optical center from the pupil will cause distortion. So generally, we do not recommend that if you have a high prescription, or if you're getting bifocals or progressives, that you buy them online, because even with bifocals, the segment for the reading, or the intermediate, or even the progressive, has to be measured accurately. If that's measured, and that cannot be done online. You cannot measure, because online you're ordering a frame, and unless you bring the frame into to our office, we cannot do the measurement properly. So I don't know how they dispense lenses online for bifocals. The most common thing that we hear about is single vision lenses. And again, with single vision lenses, if your measurement of your pupillary distance is off, and if the optical center is off, then it's going to cause problem with the vision with the glasses.
Great, thank you. Seniors, should they be worried if they cannot see small print on a document, even when at arm's length? Is this just the aging process?
No, I think over time there's I use a reading chart in my office, and the reading chart, has very small prints like that you see in the medicine bottles, and then to the very large prints. So many times people come in, and as the seniors, they will not see the very small print at the top. They will see the print below that, or below underneath that. So if you're not able to see the very small print, I would not be concerned. But again, I would advise you to get your eyes checked to make sure that you're not developing cataracts, or that you're not developing macular degeneration, because both cataracts and macular degeneration can affect your vision. So once you rule out that there's no cataract and that there's no macular degeneration, then I would not be concerned about a slight reduction in the reading vision.
Great, thank you. And for seniors, the eye exam is free anyway, right? Or covered by the government?
Yes, yeah. After 65, it's covered by OHIP.
Right. Okay. What are your comments on laser eye surgery, especially for seniors? Is it too late? Missed the ball.
Yeah, I think it's too late. So basically, if I can go back to show you a picture. So basically, laser eye surgery is recommended for people who are in their 20s and 30s, even 40s and 50s. So what laser surgery does, it treats the cornea. So basically, it removes a flap on the cornea here, and once the flap is removed, then the laser, it removes the tissue in the middle part of the cornea. Now, by removing that tissue in the middle part of the cornea, so it corrects your prescription. So if you have a prescription of, say, -3 or -5 or -6, You know, by removing the tissue in front of the cornea with the laser, that's going to correct your vision, so you don't need glasses anymore. This is how laser surgery works. Now, after the age of 60 or 65, there's no point in doing laser surgery, because if you do laser surgery, remember at 60 or 65, you also need bifocals, right? So when you do laser surgery, it only corrects your distance vision. It does not correct your near vision. So there's no correction for laser surgery for near vision. So that's why we normally recommend it for people who are in their 20s or 30s, because if they do it when they're 20, they have 25 years where they don't need glasses at all. So they don't need glasses for distance. They'll never need glasses for distance. And then for 25 years, they will never need glasses for reading. So they have 25 years of freedom from contacts or lenses. And after 45, they will only need reading glasses. Now, once you're 60 or 65, so we don't recommend laser surgery, because when you have your cataract surgery done, it does the same effect. The cataract, when the surgeon removes this lens, which is cloudy, they're going to put a new lens, and the new lens that's put in is going to correct some of the prescription that you have for distance. So if you're wearing, say, -5 or +5 for distance, when the surgeon puts in the new lens, he's going to put that +5 or -5 into the order that power into lens. So when you get the lens put in after 65 or 70, that's going to have the same effect as if you had laser surgery done when you were young. So normally, I don't recommend laser surgery for people after the age of 50 or 55, unless they really want it, because in another 10 years or 15 years, when they have cataract surgery done, that's going to have the same effect as doing laser surgery when you were younger.
Great, thank you. If someone is diagnosed, sorry, you talked about this, but maybe you can just cover that again. Any treatment for glaucoma?
Yeah, so the treatments are basically, we want to pick up the glaucoma at early stage, basically with very little peripheral loss of vision. And once we see those early changes in the peripheral vision, basically the treatment is most commonly with eye drops. And these drops have to be taken for a lifetime. There's other options available too. So if eye drops, if you're not suitable for eye drops, your ophthalmologist may recommend doing laser surgery. Now, this laser surgery is different from the laser surgery that we talked about. This laser surgery is in this area here of where we had anterior segment imaging done. And basically, what it does, it allows for the fluid to outflow more freely and reduce the pressure in the eye. So those are the two most common two options: eye drops or laser, which is known as SLT, which helps to control the pressure in the eye.
Excellent. I'm diagnosed with glaucoma, and it's controlled by eye drops. Now he needs cataract procedure to be done. Is it okay to go ahead with the procedure?
Oh yes, it's perfectly fine. In fact, it's highly recommended to have cataract surgery, because as you can see, when the lens in front of the eye becomes cloudy, when it becomes more dense. It becomes more dense. It's pushing into the front of the eye, and it's blocking the aqueous outflow in front of the eye. So to do a cataract surgery, once your glaucoma is controlled, is highly recommended, because it's going to increase the outflow of the aqueous, or the fluid in the eye, and it's going to improve your vision that you have that's reduced because of the cataract.
It's 3 o'clock or 3:02. Just a couple more questions, not too many more.
Sure.
All right. The optometrist tells you need a cataract surgery, but the surgeon says you have to wait until you have vision problems. So what do you do?
Okay.
Difference of opinion.
Okay. Again, so let me go back to the picture of the cataract. So many times when people come in, when a cataract is very small, I generally don't, personally speaking from my experience, I don't refer patients when the cataract is very young, okay, which is like an immature cataract. If I can correct that with glasses, I normally correct that with a change in the prescription for the glasses, and they're generally okay for a few more years. But as the cataract becomes more dense, then that surgery has to be done. Now, many times you may go to your optometrist, and some optometrists may refer you for a cataract. They'll say, "Oh, your cataract is ready. You have to get it done." But the ophthalmologist, based on what they see when you go and see them, they look at the cataract and they also look at the vision. They'll say, no, it's not ready, because they obviously know that it's not ready. It's not affecting your vision, so they will recommend that you wait. And again, this is very common. I see many people. Sometimes they come to me and they say, "Oh, I have cataracts," but when I check their eyes, the cataract is not, it's there, but it's not mature. It's not ready for the surgery to be done. So it's very common. I mean, if you are referred to have the surgery done, go with what the ophthalmologist recommends or the surgeon recommends. But if you're really, really concerned, then you might want to get a second opinion and go see another optometrist, and the other optometrist will tell you whether the cataract is ready or not.
Hmm. 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 So nowadays you can get cataract and laser correction at the same time. Is that recommended? Now, I didn't know that was possible, but anyway, someone's looked into it. Are you aware of that?
Yeah. So what happens when you have cataract surgery? Remember, I said that when they do order the lens, they try to incorporate the power for your eyes, so that you don't need glasses. Sometimes you may be left after the surgeon implants the new lens. You may be left with a small prescription for distance. Okay. Now, if you don't want to have that prescription for distance, the surgeon will tell you, okay, well, I can correct that small prescription that you have with laser. So they will do the laser in front of the eye. Okay, yeah. So here, so you have the lens put in, but then you're left with a small prescription. So what the surgeon would recommend is maybe doing laser to correct a small prescription. So this is the only situation where I can see where you probably have laser done after cataract surgery.
Hmm. Hmm. Okay, now I wasn't aware there were different types of progressive lenses. I thought it was just, the different brands, but is there any, the question is, what are the best progressive lenses? Any thoughts, any comments?
Yeah, so basically, again, going back to the picture of the progressive lenses, so you can see that in the middle here, we have a corridor from the distance, intermediate, and reading. So the regular progressive lenses, the corridor that you have in the middle here is very narrow. And then so you get distortion, so the distortion on the side will increase, okay? The new type of lenses that we have in the market, they're known as digital lenses. So digital lens, progressive lens, it works like your high definition TV. So there's the corridor in the middle is much larger, and because the corridor in the middle is much larger, the distortion is moved into the periphery. Okay, and because the distortion is moved into the periphery, so your central vision, your distance vision, intermediate vision, and reading vision is much sharper. So when you're paying more for a progressive lens, what you're getting are those digital high definition digital lenses. And that's why the cost is more expensive, because to reduce the distortion on the side, the design has to be digitized, and that's where the cost comes in.
Hmm. Okay, easy one. This is Optometry 101. What is 2020 vision? Can you explain that to me, please?
Yes, 2020 vision, it refers to the line that you're looking at. It subtends an angle of 20 degrees at 20 feet. Okay, so in North America, we use the 2020 vision, 2020 the 20 feet scale, whereas in Europe and the Middle East and maybe Africa, they use the 6 meter, which so 6 is the same as 2020. So basically, 6 refers to the small line. It subtends an angle of 6 degrees at 6 feet, or subtends an angle of 20 degrees at 20 feet. So this is what 2020 refers to. And so the opposite is 20. So if you go with 2400, so that means that the image is larger. So you can see the 2400, the image or the letter is very large. So it subtends a larger angle, larger degree at 20 feet or 6 meters. And this is the measurement of the angle that at that distance of that image, of that picture.
Excellent. Thank you. Thank you. Final question. Why do you see more kids wearing glasses these days? Are the newer models kind of not up to par?
Well, I'm glad you brought this up. Actually, I was going to talk about this earlier. Let me go back to my slide.
No, the presentations for seniors, but I'm just wondering.
No, so actually that's a very good question. So this is something which I've just started recently doing it. So basically what you're referring to is myopia. So the myopia is a condition that we see in young kids, okay? Young kids who are at the early age start wearing glasses for distance, and this is known as myopia. So the incidence of myopia is increasing, and the incidence of myopia is increasing because, one, kids are spending less time outdoors. Secondly, because kids are spending more time doing close work on their iPads, on their phone, at school. Even at school, for example, if somebody is very studious and spending a lot of time reading or studying in the library or home, you will notice that most of them end up with myopia. So this is what myopia is. So it's caused by because people are spending less time outdoor and spending doing more reading or work inside. And the third reason why myopia is we see an increase in myopia, because if one or both parents are myopic, chances are that the kids will end up being myopic as well too. Okay, but that's a genetic cause of myopia. But the environmental cause, there are the two leading cause is less time spent outdoor and more time spent inside looking at phones and tablets. This is why we're seeing a big increase in myopia. And in fact, the prevalence of myopia is very high in countries like Taiwan, China, and Singapore, and in Asian countries, because those kids from an early age start going to a school at an early age. So they're always reading. They're spending less time outdoor, and they're doing more and more work, school work at an early age. And this is why the incidence of myopia is very high in those countries. But the same is happening in Canada, North America, and in Canada, America, and the UK as well. So the incidence of myopia is increasing, and this is why we're seeing more kids with glasses nowadays.
Yeah, makes sense. So when kids are reading in poor light, they used to say that your eyes will go bad. Is it true, or?
Yes, I mean you want to, if kids are reading in bed, I always recommend make sure you have the lights on, because there's less information available in a dim light for the eyes to focus. So you can imagine that with reading in dim lights, they're accommodating their eyes, and And chances are that the prescription will probably increase over time if they keep doing that.
Hmm, hmm, hmm. Well, I think we've kept you long enough, 3:12. Dr. Rawji, this was a fantastic presentation. It was packed with lots and lots of information. Really, really appreciate it. You know, we are so fortunate that, you know, our community has, you know, all these brains like yours. And, you know, we seniors can sort of tap into the knowledge you have. So thank you again. Thank you so much.
It was my pleasure.
For our audience, no baraza next week. Have a wonderful Eid. Happy Eid. Eid Mubarak. When it comes, not before. And the week after, we'll have a presentation on Uyghurs in China, their plight, what they're going through. Thank you. Take care. Be safe. That is.
Hafiz.
Thank you, Mustafa.